session during the 13th European Congress on Global Health. We're very excited you're here with us today to talk about racism, inequity, health and well-being. On behalf of the local organizing committee, I'm very pleased that we're able to provide a stage for this important topic. It's a topic we need to discuss, we don't discuss enough, and we need to talk about more. So let's use today to start with this, or continue with this. My name is Joyce Brown. I'm an associate professor in global health and epidemiology, and together with Wouter, I'll be your moderator.
And my name is Wouter Arazola Deoniati. I'm a medical doctor in public health, working on social determinants and tuberculosis. What will happen this afternoon is, first of all, we're going to have a short presentation by Professor Delan Devakumar on the topic. After, we will have two questions. We will take two questions from the audience and answer them. After that one, we will one by one introduce the high-level panel, I may say. We're very honored to have the guests here. And we will start the debate. So, first of all, honored to have you here, Professor Delan Devakumar. Delan is professor of global health, global child health, I must say, at University College London, honorary consultant in public health, with clinical expertise in pediatrics and humanitarian contexts. He was the lead for the Lancet Series on racism, xenophobia, discrimination, and health, and is the founder of the UCL Race and Health Group. Very interesting group. You have to look it up online. And he is the chair of a new commission, the Lancet Commission on Racism and Child Health. Very much looking forward to the work of the commission. And now, of course, to your presentation. Thank you.
Thank you. Thank you very much for inviting me here today. I'm going to talk to you a little bit about the Lancet Series on racism, xenophobia, discrimination, and health. I can get this to work. So this work began in 2019, and these were happy times when racism didn't exist. But then the conversation changed in 2020, at the start of the COVID-19 pandemic, when we started to see attacks against particularly East Asian people as the pandemic started. And then we saw increasing anti-migrant sentiment and closing of borders around protection against infection. And then the murder of George Floyd led to mass conversations and protests around racism, the Black Lives Matter protests. But it's important to say that this isn't about individual acts of violence and not about a few bad apples. This is about the fundamental and deeply rooted systems of oppression that result in the deaths of innocent people. And this was seen starkly in the COVID-19 pandemic. This is data from the Office for National Statistics in the UK. And it showed an increased mortality amongst Bangladeshi women of 4 times compared to white women. Amongst Bangladeshi men, it was a 5 times increased mortality. And the reasons for this are multiple and complex, and it relates to an increased risk of getting the infection in the first place. Bangladeshi, Pakistani people are more likely to work in the service industry, more likely to come in contact with others, more likely to live in multi-generational and crowded households to transmit the infection from person to person. Also more likely to have underlying non-communicable diseases. That means that when you get COVID, you become more unwell. And finally, there are barriers to the health system. In the UK, we have a national health system, but there are barriers for migrants who come to the UK. So in this work, we looked at what racism is, and we looked at some of the history and the politics, and then we looked at health outcomes and interventions. We defined racism broadly as an organized system that affords power and privilege according to an established hierarchy. And we looked at this across the world because there are similar systems and drivers and health consequences based on someone's ethnicity, on caste, on indigenous status, migratory status, race, religion, skin color. We then looked at xenophobia, and that's a very similar concept, but it's about discrimination, hatred of foreigners, of other people. But very often we see an overlap of these, where certain migrants are treated in one way and certain migrants are treated in a different way. And that certainly happens in the UK, where I come from. And then discrimination, differential treatment or outcomes based on someone's group. So for racism to exist, we need racial categories. And this goes back to the 1700s, to Blumenbach and to Linnaeus. The colors that Blumenbach described are still used commonly today. Carl Linnaeus then went one step further to add characteristics and behaviors to those groups. Americanus being obstinate, merry. Asiaticus, melancholy, haughty. Africanus, crafty, indolent. And of course, Europeanists were sanguine, muscular, inventive, like themselves. And these ideas, these kind of racist connotations, are there within medicine, within health and science in general. And I stand here as a professor of global child health from University College London, the scientific home of the eugenics movement. A quote by Francis Galton, the famous statistician: "Eugenics deals with what is more valuable than money or lands, namely the heritage of high character, capable brains, fine physique and vigor. It aims at the evolution and preservation of high races of men like Francis Galton." Eugenics divided people into two groups, those who are worthy to give life and those who are not. And a recent inquiry within UCL into the history of eugenics talks about how this idea is still present today. Around the world, eugenics of one form or another is implicated in compulsory sterilization, legislation on mental deficiency, immigration law and racist policies, the notion of natural intelligence, normalization of segregation by race, ability, and class. These ideas are still ingrained in society, within medicine, within healthcare. So within the series, we looked across multiple levels. We started off with the individual person, and we looked at the ways that racism can lead to health outcomes in biological, psychological, and physiological pathways. There are the most obvious kinds of pathways where someone may be attacked, and that's kind of clearly a racist attack. But underneath, there are more complicated pathways involving stress hormones, overactivation of neuroendocrine system, that can lead to outcomes that can present later in life, particularly non-communicable diseases. And we summarize the health outcomes by life stage, and this isn't to go into any one, they're very small there, but just to say that there are a lot of health outcomes. And this is probably an underestimation. There isn't a massive amount of research into this topic, and the research tends to be focused in particular countries, particularly the US, where most of the research is done. We then thought about the communities that those people live in, communities that may be supportive, that may protect the individual person, but also communities that could act in the opposite way and increase racism towards those people. We then thought about the environments that people live in. And this is, I guess, most starkly for indigenous people whose lands are destroyed and as part of racist attacks. But this also occurs in London, for example, where I work. There's an increasing debate around air pollution within London. But what we see is that different groups within London breathe in different air. This is within one city, we get this division according to racial or ethnic group. We then focused on the underlying causes, and this is something we really wanted to stress within the series. While most people think about the individual on the outside, the underlying causes, the structural reasons of why racism continues. And here we talked about separation and hierarchy. Separation, people being separated into different groups, and then hierarchy, where those groups, one group is above another. And that's the main problem. Separation is very common. We have this within sports teams in a city, but it's that hierarchy. Certain people are considered better, deemed more worthy of rights than other groups. And this would work through systems and institutions and through different pathways. We then added a ring around this to talk about life stages. So being a child health doctor, there are particularly sensitive stages in early life in particular, where racism can present differently and then lead to these outcomes decades later. We had a particular focus on the health system, and there are many ways in which the health system can be racist or can protect against racism. That can be through discriminatory acts, overt discrimination by health workers or experienced by health workers, issues of acceptability, the quality of care that different groups face, the access to care. I mentioned migrants being excluded within the UK health system. And it's important to say that this may not be deliberate. This can just be the way the system is set up. Sometimes we have algorithms within medicine that automatically correct for race, kidney algorithms, for example. This isn't about an individual being actively racist. This is about the whole way that the system is set up. We then looked at intersectionality, and we looked at case studies around the world taking an intersectional approach, trying to look at the ways in which racism may play out in different areas and similarities and differences. And we saw this idea of separation and hierarchy in all the case studies, the importance of history, the colonial history in particular, the effects of violence, direct violence, but also structural violence that played out in similar ways around the world. We then looked at interventions, which we categorized by the level in our conceptual model. Most of the interventions tended to be on the individual level. They tended to be short-lasting, not very successful. The interventions that were more successful were in the core of this model, the structural interventions, where you change a law, you change a constitution. But of course, that's very difficult, and implementing those changes can be very challenging. So our kind of take-home message here is that action needs to be at all these levels. We might try to change the structural cause, but then you can't ignore the person who turns up to an emergency department. We then looked at this particularly in relation to climate change, and we mapped issues of climate and racial justice around the world. We did a review on this. I talked about air pollution, indigenous people, and there are multiple forms in which racism can act in terms of environmental health and climate change. But underlying this is the politics, and it's an election here today, so it's particularly important today. But increasingly, we're seeing populist politics play out around the world. The most powerful leaders in the world stand on an agenda of division, of scapegoating other people. In the UK, it's about migrants, these people coming across the channel, taking our resources, when the reality is that a very small percentage of migrants actually make that journey across the channel. And these are some of the most vulnerable people who have the greatest vulnerabilities as they cross the channel. But this division is at the heart of what the problems are that has been very successful, but we need to challenge. And finally, we came up with 6 principles of action that can maybe guide some of the work that you're doing. These ideas of decolonization, of justice, of intersectionality, taking an anti-racist approach, an actively anti-racist approach, a human rights approach. And so the key messages from this series that we did was that racism is important. It's a fundamental determinant of health. And it occurs in a similar kind of form across the world, in every society across the world. And the root of that is the structural cause. And the focus, you need to think about the structural causes at play. If you're interested in this work, do have a look at our Race and Health website, which was mentioned just before, www.raceandhealth.org. This has the academic work, and we seek to transmit this work in different ways. We have a newsletter which has media content and different kinds of content. We have a podcast where we talk about the issues, webinars, comics, films, a variety of different things. And I realize I've gone over time, but I've got a short animation. I can stand here and talk about racism in a very abstract way, a conceptual model in these numbers and history, but racism is a very personal thing. So one thing we did was to ask people, what does racism mean to you? And we put this short animation together.
El racismo para mí significa definir a otro como distinto y diferente a mí, de una manera tal que vale menos como persona. Por ejemplo, en Chile, donde yo vivo, crecí en una familia donde el tener color de piel blanco, ojos claros o color de cabello claro tenía mayor valía, y yo, siendo morena, sentí desde muy pequeña que yo entonces era menos bonita, o lo que decía o pensaba importaba menos. En el espacio profesional también he sentido experiencias de ser definida como menor valía por ser latina en Europa, lo que hace que uno viva la vida desde un lugar de más miedo, de mayor inseguridad sobre lo que piensa, hace o dice.
Racism to me is the beauty standard that we have in Samoa. If you look more indigenous or local, people will treat you in a way that is less than they would treat a foreigner.
My first awareness of racism was as a young brown child visiting the UK. It was to feel judged or watched every time I went into a shop or boarded a bus. It was to know implicitly that I was considered to be a different category of person than the members of a more powerful majority. It was to feel that I had to be an exemplary representative of my minority group who was deserving of acceptance, and to know that I always had to be alert to my precarious position. When I returned to live in Sri Lanka, my situation was completely reversed. I was privileged to be a member of the majority, and it was my neighbors, friends, and colleagues from minority groups who lived with the very real possibility of violence that could threaten their homes and lives.
I recognize racism in our school systems, but in the form of colonialism. As a Ugandan citizen, we were colonized by the British, which means that we had to adopt the British education system. However, years after we have gotten our independence, we are still, to a larger extent, being taught with the same education structure, which to me feels just not right. To a larger extent, the education that most Africans are getting is still colonized, so it makes it very unrelatable to young people.
Racismo é que é errado a gente falar mal da pessoa só por o jeito que ela é. É muito errado. Então eu ia falar para a professora quem tá fazendo racismo, para ela conversar. E é isso.
So thank you to all the speakers, in particular Mita Hawk, who produced that film. So finally, if you'd like to find out more about the Racism Series, that's in the QR code at the bottom. The upper code has the previous work on migration and health. Our new work, as was mentioned, is on racism and child health, and that's starting now. You can find out more on the website. Children are often ignored from this conversation, but if we want to make a change, we have to focus on children. Thank you very much.
We promised you would get to ask 2 questions. So I would like to see a raise of hands to see who I can invite for the catchbox to be thrown. Yes, a very eager hand. Please introduce yourself and your name so we know who is asking the question. Yes, it's working. Go for it.
Hi, I'm Serena Cruz. I find this very exciting. I'm so grateful for the organizers, conveners of this Congress to make this a priority topic. My questions are of a more academic nature. What were the decisions that went into the themes that you wanted to explore for the work? And how is it that, and maybe it's in there, but not central, how is it that sex, gender, and also class did not come up in your presentation starkly? Thank you.
Thank you. So we looked at issues where there was very similar kinds of oppression and lots of overlap, so race and ethnicity and migration. So we can see lots of similarities in how they play out and the ways that they play out. We did look at gender, class, disabilities, so particularly within that third paper on intersectionality, and that's where we brought in these other aspects. So, of course, each person has different identities and multiple identities. We were also thinking a little bit about the other work that's happening. So there's similar commission on gender and health, for example, that focuses very much on that. So we thought some of that work had been done, but we think, absolutely they're important. And what we do is think about that intersection between migration and gender, for example.
Thank you.
I saw a hand over
You
there.
want to-
Did you see the same hand?
Saw the
Well.
same hand, so please go ahead.
It's me?
Yes, it's you, Denise. And sorry, yes, you have a catch box in your hand that you can talk. Yeah,
Okay, this is working. Okay.
yes.
This is Deniz Aydemir'döke. I have a question. In your work, you said you started in 2019. Since then, what type of institutional support and resistance did you face, if it's okay to disclose here?
Sorry, what kind of institutional support have we had? Support or resistance?
What kind
Support
of
or resist?
institutional support or resistance that you
Yeah.
face in the work that you've been doing?
So I think in terms of support, certainly within my university, as I mentioned, this work kind of followed on from the work on migration and health. And certainly within the Lancet, they've been very supportive in trying to help this work and the commissions that we have now as well. Resistance, I think it's hard to say in that there's a kind of resistance which is just ignoring the work. So I think that's one thing where you talk about it and then it just bypasses and nothing happens. I think there was certainly a much more active conversation in 2020, and that I feel is waning over time. It seems less important now than it was. Getting funding is a form of resistance. We found it very hard to get funding for this kind of work. What I was hoping to do is to just raise this up the agenda, for people to think about this, for people, clinicians who are working day to day, for administrators, for policymakers ideally, for this to hit their agenda, for them to think about racism as one of the aspects alongside some of the other major determinants of health. And hopefully that's moved up a little.
Maybe one example, for the first time in history at the World Health Summit, there was a whole session on racism and global health, which is a direct consequence of the work of all the people that collaborated at the Lancet Series and the commissions. So there is a momentum now. So this moment is not a one-time shot. This is only the starting point of a growing movement towards a better world, let's say.
And maybe that's a nice lead up to the next bit. It's a growing movement and we need many, many people. And we're really honored to have a panel that is a testimony to a number of experts that we have already in the world in this field, but also how important it is that we do not only approach it from an academic or healthcare perspective, but also include policymakers.
Yes, and I would love to invite the first guest, a monument in research, Professor Charles Adjemang, Professor of Global Migration, Ethnicity and Health, Principal Investigator at Amsterdam University Medical Center, and Adjunct Professor at Johns Hopkins School of Medicine, Vice President of the Migrant Health Section of the European Public Health Association, and Scientific Chair of the Global Society of Migration, Ethnicity, Race and Health, and a Fellow of the prestigious European Research Council. Yes, Charles. And also, one more thing, recently elected at the US National Academy of Medicine. Congratulations for that. Second guest, Dr. Alana Elber-Proctor. She is an assistant professor in the Health, Care and Body program group, at the University of Amsterdam Department of Anthropology. In her work, she focuses on diversity and inequality in healthcare and medical science. She investigates how race and ethnicity appear in biomedical research, health policy, and healthcare in the Netherlands and in Europe. Welcome. Third honored guest, Dr. Amma Kissi. She is a PhD, a postdoctoral researcher at Ghent University, Belgium. Her research aims at identifying factors that may explain racism in healthcare, with a particular focus on the assessment and treatment of pain. Besides conducting research, Dr. Kissi also works as a diversity and inclusion consultant and clinical psychologist, and offers workshops on diversity competence in healthcare.
Welcome.
Next guest, number 4, Dr. Nilofar Ashtiani. She's a pediatrician with a special interest in gastroenterology, functional somatic disorders, and childhood obesitas. The chair of an organization that aims to improve the health of refugee children in the Netherlands. Founder of Co-Master, an organization that aims to provide open source, inclusive medical education through innovative digital technology, and many other organizations dealing with inclusive communication courses for all healthcare professionals, among others.
We were not done yet. We have 3 more incredible experts to welcome on stage or online. The first I would like to introduce is Abigail Norville. She's the Deputy Secretary General of the Ministry of Health, Welfare and Sports of the Netherlands. And throughout her career in several senior management positions, she has been a strong and effective advocate for inclusion and a diverse workforce. An example is the program she initiated at the ministry to onboard and recruit more streetwise professionals who have experiential knowledge next to other types of knowledges. She's also the chair of the board of a public broadcast channel, Zwart, Black in English, and it's a new public broadcast channel in the Netherlands that makes programs for a new and diverse audience. Welcome. And next, Dr. Bahar Godarzi. She's a midwife, a teacher at the Midwifery Academy in Amsterdam, and a postdoctoral researcher at the Department of Midwifery Sciences at the AUMC, the University Medical Center Groningen, up in the north of the Netherlands, and APHA. There are 3 joint institutions. The focus of her work is reproductive justice, and she's the founder or the initiator of the Critical Midwifery Studies Collective, together with a number of other experts in the field who are building a new domain. She's a strong advocate for research into reproductive justice from a critical point of view, and she's currently writing a book on reproductive justice. And finally, we turn online. Yes, and we're very pleased that this worked. We already did a pre-test before to Ms. Michaela Moa. She is the EU coordinator of anti-racism, joins us from Brussels, where she works on the EU policy level to fight racism and to help member states transition with anti-racist policies. She has a long time experience in this in her native country of Finland and has been able to carry all this experience into her current position. Welcome, and we're very honored you're here.
So let's start the debate or the questions. We would love to have an interactive session, so feel free to make a sign if you want to interact or ask something. We already heard from Delan, Professor Divakumar, that there's a lot of research done on racism as a social determinant of health, but what is very particular is that a huge chunk of it, 80% almost, of this research is being done in North America, the US. Around 10% of it in the UK, Canada, Australia, New Zealand, and the other 10% in all the other countries, including Europe. So there is not a lot of research in Europe that uses the term racism when it comes to health. We do believe it is still a social determinant in Europe as well. We would like to invite two panelists to reflect on it. And the first one is Madame Michaela Mua, and next to that is Charles Adjemang. Michaela, go ahead.
Just want to make sure that you can hear me.
Yes. Perfectly.
Wonderful. Wonderful. First of all, I just want to congratulate you, Wouter and Joyce, on this very timely and extremely important panel. Thank you for having me here today. And Dylan, thank you very much for this important presentation of the work that you have been involved in, and really for pointing out also the geographical disproportionality of knowledge, data, and research related to racism and the area of health. Unfortunately, we, exactly as mentioned, on the EU level, we must consult studies on racism and health from the US and the UK, and by now, the work that's done in the EU is quite scarce as far as focusing specifically on racism and the area of health. But let me briefly start with my mandate. In 2020, a few months after the murder of George Floyd, the EU adopted the EU Anti-Racism Action Plan, which is a 5-year action plan spanning until 2025. And in 2021, I was appointed as the first EU anti-racism coordinator, as mentioned by Joyce. And in a nutshell, my job is to oversee the implementation of the EU action plan on combating racism. And it's been quite a relevant milestone in the European struggle against racism. Mainly, I think one of the main things that it really brings is that it recognizes structural racism as a starting point, as something that's deeply embedded in our society's history and intertwined also with its cultural roots and norms, and something that can be reflected in the way society functions, how power is distributed, and how people interact with the state and public services. And here we're today talking about specifically the health sector. The impact of structural racism, I think, was very well put into words much more eloquently than I would be able to, about the impact of such structural and systemic racism, and how it can be harmful. It can be harmful on so many levels, but beyond only the individual level of racism. And its existence really needs to be, in a sense, the starting point of proactive policies. And also the intersectional aspect, which was mentioned, really can also deepen the understanding of structural racism. What we are at the Commission really trying to move forward is the collection of such equality data based on the 6 grounds that are in the treaty, but also, of course, the grounds of race or ethnicity. And here, I recently read that substantial evidence on vast racial inequalities in health in the US has been well documented, and that racial health inequities have been part of government statistics since the foundation of colonial America. And well, here in Europe, we're at a very different stage. We have member states that are specifically when it comes to collecting disaggregated data on race or ethnicity, are quite opposed or are using proxies that are not really uncovering the information we're looking for. They might use proxies such as birth country of parents, or a mother tongue, or place of birth, that when it comes to 3rd and 4th generation racialized people that have lived here already for centuries, it might not kind of bring up the inequities that we're looking for, or the link between racial discrimination. And as a Black European woman, I'm, for instance, not properly reflected. And my experience as such doesn't become part of the equation. So these are some of the big hurdles, because of course such data always, we have to remember, has to be collected with constitutional norms, respecting the GDPR, and also the basic human rights principles related to data collection, participation, data desegregation, self-identification, transparency, privacy, and accountability. But to some of the recent data that has been collected was related to health specifically by the European Union Agency for Fundamental Rights, was through the Being Black in the EU report that was published in October, which showed that specifically when it comes to Black people in the EU, they faced structural discrimination not only in all areas of life, but in the area of health. It showed that 1 in 10 respondents feel racially discriminated against, but also when using healthcare services, they're having unmet medical needs. And I think this reflects well back to also what was mentioned by Dylan. But I'll finish here and perhaps come back if I still have the opportunity.
Yes, definitely. Please come back when you have the opportunity and you want to give more input. And we go to the next speaker, is Charles, because you did a huge amount of research in Europe. So what is your opinion about the first statement, let's say?
Yeah, I think...
The mic?
Yes.
Yeah. Can you hear me? Yeah.
Yes, we can hear you.
Yeah, I think it's actually, this is not surprising that if you look at UK and America, where there's a lot of data, and within Europe is quite hard. And that has to do with some of the issues that's already been raised, right? In most countries, it's actually quite difficult to collect data by ethnic status, right? And that makes it difficult to be able to do any study at all. I mean, we know that in some countries, it's actually, some people actually get into trouble for trying even to do that. And that means that, have a lot of consequences. For instance, and the typical example is actually when the COVID situation happened. All of a sudden, you're getting a lot of data from the UK and then the US. Across Europe, including the Netherlands, it took us a long time before you'd be able to come out with the data. Even that was a constant struggle. So therefore, it's not surprising that actually you do not have data across European, across continental Europe. But actually, if you look at some of the small data, my group, you have used the Helios study, which is basically a huge study within Amsterdam, to give us a little bit of an idea what is going on. But if you look at the data, it's more or less exactly the same like what you're saying. You know that, for instance, within Amsterdam, if you look at, self-perceived discrimination, if you ask the European population, just about 1.8 will say that they have experienced discrimination. If you ask the various minority or the migrant population, it starts from 28 to up to about 30%. You have a huge differences within this population. So the little data that is up there shows that there is a huge inequality. But the real discrimination part, probably I would say that it's kind of, if you like, the elephant in the room. Everyone knows it, but no one wants to talk about it. And that is a big, big issue. In relation to health as well, I mean, the team, you have done a lot of work, but it is very, very clear that if you are discriminated against, have a huge repercussions on several health outcomes, including mental health, including cardiovascular health, including many, many other things. And more importantly, the people that actually experience this, they also actually get isolated from the society. So in a way, discrimination not only is affecting the people, it also has consequences to the wider society, because basically if people get discriminated against, they get isolated. They don't actually involve more in the society. And then you get, now and again, you get what is happening in France and elsewhere else. These young people come in, and they start basically want justice. So it is in the best interest of the society to actually look at discrimination. We cannot continue to basically to put it under the carpet. We know it's there. And therefore, within Europe, I think that we should potentially follow some of the examples in the US, in the UK, and really start looking at it and start basically talking about it. You know, I also know that when they talk in terms of discrimination, I would say that discrimination is a very, very fine and difficult topic because it's uncomfortable for those who are being discriminated against and those who are doing it. Mm-hmm. If you look at the literature, for instance, you know, there is no clinician, there is no someone else working in health who want to be seen as being discriminatory. No way. But then if you look at the literature, it's all over the place. So there is mismatch. And that has to deal with the way discrimination is handled within society. So potentially, or what I would suggest that we need to basically come out with a situation whereby people feel comfortable to be able to talk about a topic. If you're unable to talk about a topic, then everyone else who basically don't want to be involved. And if people are not talking, then we are not getting anywhere. So we need to come out and find a way where we can basically discuss it in such a way that people can appreciate it. It's there, it's the elephant in the room, so that you can basically do something about it. I mean, I can talk about it, but because of time, I'll hand over to you. Thank you.
Thank you, yes, and we will come back to the example of the UK later.
Before we move to the next question, I do want to check in with the panelists if any of you would like to respond to either of the two contributions so far. Yes, Xenophobia, please go ahead. And for everyone, we did agree to talk to each other on first-name basis. That's why I'm addressing you as Nilu. Yeah.
Well, I just wanted to add a small note to say that more than 50% of all children in the world are now have a multi-ethnicity. So this problem of classifying patients is going to increase. And so we really need to think about that as a scientific society. Like, what do we want to agree on? And it matters. We know that it matters. Why does it matter? And how do we want to classify children or population in general?
Yes. And how do we deal with all the complexity? And I see Abigail, yes, you. Please go ahead.
Yeah, I just want to add that it's not only a problem in healthcare, but also in companies. Because so many people tell me we need to count. And then I say, okay, so how do you count my children? Because they are born in Rotterdam, in Holland. Two parents, well, I still have the allochtone status, and their father also has it, but we didn't pass it through. But they are of multi-offspring. So how do you count? So it's not only a thing in healthcare, it's also for companies, businesses, and everyone.
Can I
yes,
add something small? And then you also have the problem of self-assigned or assigned by someone else. And in many databases, it's both, but you don't know which part of it was self-assigned. And so you see that in maternal and newborn care a lot, where we have registered data. And you don't know whether the practitioner has assigned the ethnicity to the pregnant person, or that pregnant person said, well, I identify as such and such. So that really biases the data.
Yes, and if you allow, Amma, please go ahead. And Alana, I also would like to hear your thoughts, because this is your area.
But what I have to say does not necessarily have to do with the difficulties that we have concerning the conceptualization of these concepts of race and ethnicity. But it has to do more with the fact that until now, what people often think about when they think about racism, like in healthcare and stuff like that, is they think about the racism that adults face. Whereas literature actually really shows that we see this when we look at child populations as well. So although kids are often perceived as being cute, etc., yeah, most kids are cute, but we do see that healthcare providers also discriminate these kids. And I think it's important to really take this into account, because we know that like certain health complaints or like pain complaints that are not treated adequately in childhood, is actually a predictor of health problems later in life. So I just wanted to add that into the mix, that we don't forget the kids here. Yeah.
Thank you. And Alana?
Yeah, maybe I'll just keep it short. But I think analytically it's important to really be very nuanced about what we're speaking about, because the panel is about racism, of course, and for me, I think we need to kind of undo the thinking that in order to find racism, we have to racialize groups. So I think that's also in the methods, methodologically, some of the categorization complications come from there. Like we can also think about racism without necessarily having to racialize groups, because we might actually reify the very thinking that causes racism. But I'm sure we'll get back to this.
Well, yeah. Yes, we will, because it's an important topic, both the continuous complexity of how to classify, but also how in what we do, we don't actually amplify and create a bigger problem instead of solving it. I want to follow up on what we started with Michaela's contribution on a European Union level, and I want to bring it to a member state level. So, Abigail, from a policy perspective, what can we do on a national and maybe local level to reduce these inequities associated with racism and discrimination?
Yeah, well, I don't think there's one silver bullet that we can aim. If it was there, we already would have used it. For me, I've been working now at the ministry for 4 years, and I see that after the excuses for the part of in slavery of Holland, I see at different ministries that it really leveled up. And we're not there yet, but I can see a big change in how my colleagues are thinking about this issue. So there has been a special, well, it's not a special agent, but a special person appointed by the Dutch government to oversee discrimination and racism in well, the whole of Holland, but especially in public services. And to talk about healthcare, I have a special program within the ministry to get the conversation going. But also we have special programs and also have funds to stimulate research on discrimination and healthcare. For me, in the conversation that I have, I also speak to organizations who, for instance, test new medicines or new ways of working on people. And there we also have the discussion about how do you engage more people, not only from with a white or Dutch background to participate in those researches, because medicines need to be tested on all kinds of people with all kinds of genetic build-up. So that's what I'm doing, and of course I have the Streetwise program also, but that's not especially for healthcare, that's for the ministry, for the civil servants, where I recruit people with an education, but also with a streetwise mentality, and who maybe did not follow a right path up to have their education, but maybe they had to have a pause because they had to help family, or come from another country and took a longer road to get where they are. And I think that's a very important, well, life experience that we can use in the ministry.
Thank you. And Ama, from your work as a health practitioner, you already alluded to the fact that even in childcare and child healthcare, we see racist behaviors, unintended or intended, but there is a system where we don't treat every child in the same way. What are your recommendations? What can health professionals do?
Okay, thank you so much for that question. I think it's an important question to ask. Today I'm here as a healthcare provider, but at the same time also as a scientist, right? Mm-hmm. And one of the things that I would like to mention is the fact that if you look into the literature, what we've seen is that these health inequities have been documented for several decades now. But what we don't really have we don't really have a robust, empirically informed understanding of the mechanisms that may account for racial discrimination or racism within healthcare, right? So I think if we are thinking about what can healthcare providers do and stuff like that, I think we need to have more research into these mechanisms that can actually inform tangible interventions that we can come up with, right? And so I think that that's a major thing. Another thing to address is the fact that when we're thinking about healthcare, we usually focus on these healthcare providers only. And when I give workshops on diversity, sensitivity, or competences, of course, I focus on these healthcare providers because they have a lot of power in that dynamic. But at the same time, I think it's crucial that we focus on victims or potential victims of racism in healthcare. We need to make them more knowledgeable, give them information about the fact that racism in healthcare does exist. Because as a person of color, you usually feel it, you experience it, but then you often think that, well, maybe it's just like I'm maybe seeing stuff that aren't really real. So I think we need to empower people by giving them information, and then we need to give them precise tools that can help them to be more assertive in that interaction with their healthcare providers. So I think that's an important thing that we need to do. And another thing that I've noticed is that when we're actually developing these interventions or applying these interventions, we often, take on a superior role or something, like as an academic or as a healthcare provider, and we think like, okay, this is perhaps the way to do it. But I think it's important to really include these patients and communities as at risk, so that when we develop these interventions, we know that these interventions actually map onto the needs that they have, that these populations have, and are sensitive enough to these needs of the communities that we actually want to serve.
As a little, and maybe for everyone good to know, also for the panel, a little bit unexpected intervention, actually I want to draw you to the images that we have projected in front of us, because I think they speak to what you just mentioned. Michaela, we'll swap the screen for a second, but you can still join us and we can still hear you. Can you show the slides, please? Yes, because this is the work of Saskia Duis and Niloufar. Can I invite you to elaborate a little bit? Because we had a session yesterday on the art and stories and art and science behind the art we have at this European Congress on Global Health. And her work is actually here, it's upstairs, so everyone is invited to go watch it. But I think this alludes to this inclusion and co-creation with patients of what is meaningful.
Yeah, so the work of Saskia Duis was really amazing. She worked with a photographer where they interviewed caregivers and informal caregivers and tried to understand their own background, their own identity. And they mirrored their experience of being so caught up in working for other people and serving others that they sometimes forgot or became invisible themselves. And they did this program where they photographed these individuals in different settings, where in one setting they're actually invisible and erased from the picture, and in the other ones they're visible in their whole flamboyant characteristic of who they are really inside, like their real identity that they're willing to share and show in that instance. So it's very powerful, I think.
Thank you.
Thank you.
And for everyone, an open invitation to watch it in the foyer. It's
Yeah, so now we have this good basis foundation of the work of the Lancet Commission and the series. So the next question is, what are next steps based on that to take as a research community? A lot of us are researchers, or I'm not a researcher, more activist. What can we do to for a better understanding of the impact of racism on health and initiate the transformations that were talked about? But how do we do it without reproducing the harms associated with ethnicity, race in research? And I want to address that question to Alana and Bahar.
Okay. Difficult question. Yeah. How do we do it? I approach it slightly differently, I think. So I'm a social scientist. I'm within anthropology of medicine. Hello.
More science. Show hands for social scientists here.
All right.
Yeah. So as a social scientist and specifically a science and technology scholar, I analyze kind of what the narrative is in the larger body. And I think in order to do something about racism as a cause of health inequalities, we have the framework, right? We have the research, the interventions, and a very good blueprint of what to do. But I think it's important to understand why is there so little space within the European context to do that. And as a true social scientist, I have a theory about this, which to me is what I call a lethal triangle of different narratives. And this triangle works to basically reduce the space that we have to put racism forward as an explanation for health inequalities. So if we look at health inequalities and we explain them away through this triangle, there's no space for racism. And what is this triangle? So this triangle has three elements, obviously. The first one is that we understand health inequalities as biological difference, right? Which is quite logical if you're looking at medicine, but this is a trap. Right? By explaining something away as biology, you take away truly, the need to understand the cause of it, because you have it, it's biology. The second one, which is very particular to the Dutch context, which is a lot of my research is on the Netherlands, is the cultural deficit explanation. So this is kind of the model where you see health inequalities and you focus the cause of these inequalities within the group affected by saying, well, it's a cultural deficit. They're not integrated. Their culture does this. This is how they eat. They don't have these and these norms or values in their culture. And then the last one is a larger narrative within health, which is the individualized lifestyle narrative, right? The idea that your health is kind of the sum of your individual good choices or lack thereof. And when you put these three narratives together, you really close any space that you have to really address racism. It becomes kind of a small add-on to other things. So I think that in order to do something, we need to be very critical and, first of all, aware, but also critical of these traps of explaining away health inequalities through biology, culture, and lifestyle, and indeed foreground all of these other factors that we know exist. And that is a systemic approach, right? Who has to do that work of creating this space? Well, we have to hold ourselves accountable. So it's us as researchers, but also the work that we do as teachers, as reviewers, as editors. We can no longer use race as kind of a self-explanatory concept where everyone can use it as they wish. We have to be very critical and hold ourselves accountable and always foreground racism and not have it as kind of an optional add-on, if you like.
I'm going to add a small thing to your story, and then I have 2 points that I would like to add as well. This is especially important when you connect medical, so in medicine, connect medical interventions with these health disparities. So what I see in maternal newborn care, for example, is that we have these disparities and then we individualize the problem or explain them as a biological cause, and then we introduce medical interventions to solve them, and these medical interventions have all kinds of risks. So what happens is that you have these marginalized groups that are made vulnerable, that have in worse health, have higher risks of dying, higher risks of losing their children, and then are also exposed to these medical interventions such as cesarean, because assumably their bodies are less equipped to be pregnant or give birth. And this is like, to me, this makes me feel ashamed to be a practitioner, because this happens every day. And this adds, so the first point I want to make is, I think a way forward is to make sure that the research that is done actually trickles down to practice and education. Because what you see is, again, in maternal and newborn care, there is a lot of work done on racism and maternal newborn outcomes. For example, the idea that the pelvis of a black person is less equipped to give birth compared to a white person is complete. I mean, that's not true. And there is so much work done from anthropological point of view, from a healthcare point of view, from biomedical point of view. But I still use a book that is used internationally to teach midwives and obstetricians that states that if you belong to the white race, your success factor of giving birth is higher. Now, I wonder, how the hell do we still teach these racialized ideas? And also, again, as a teacher, I feel ashamed to stand there, and there are no other books to use. So that's, I think, very, very important that researchers work together with practitioners. And I can give you like tons of examples about how this also works through in practice, but we don't have the time. But work with practitioners and with educators to make sure that this research that we do, that we invest money in, trickles down so we can teach the next generation so it can disappear. And the second point I want to make is, I wonder if we could get new knowledge, if we would turn the perspective around. So what I see happening is that we study racialized groups, victims of racism. What would happen if we would study the privileged groups? What happens, what I see, is that when we study the racialized group or the marginalized group or the victims of racism, is that the narrative often is, because we have that triangle that Alana was talking about, is, oh, these poor people, they should eat better, and they, you know, and especially in our society, which is individualized and everyone is held accountable for their own health and their own success, they should have worked harder, should have had a better job, should have, I don't know what they should have done, but it's never about the system and the institutional racism. Whereas maybe if we turn it around and we look at the privileged groups and look at how is it that they do better? What access do they have? What competencies do they have? What do they have that others don't? And there are few studies from the United States that, for me, are examples that could give us more information. There's, for example, one study conducted under the white population and health outcomes. And what that study shows is that white people are, especially in the US, where you have the American dream, are raised with the idea of you have the right to a job, you have the right to a car, you have a right to a big screen TV, you have a right to a house. And when they end up not having them, they show racism as a way to explain why they don't have it. We have those foreigners stealing our jobs. And that actually also gives them a lot of stress, the idea that they don't have it. So I think these kind of studies can also help us, like you said, understand the mechanisms, and it requires an intersectional approach, because in this study, class was very important. And we see that also in the history of slavery, that class was used to set like white and black people against each other. And yeah, I think I made my point.
Thank you very much. I see.
Let's go to the audience. That's okay. Thank you all for all your contributions so far. And there are a few other topics we would love to discuss. But before we get there, I do want to make sure the audience gets an opportunity to ask a question they would like to ask. I see a hand raised there, and I see a hand raised there. Let's take both of them. Yeah, first person sitting there.
But please keep the questions brief. And,
yes.
No monologues.
No.
We all know.
Question as a comment type thing.
Yes.
Okay, thank you. My name is Samuel. I'm a medical doctor. I work for the Belgian Development Agency. And I hear you talking about this very important topic, underestimated. And I was thinking, isn't this a repeating of the same story that was happening, I mean, earlier in the century with poor and rich people? And if I think of the class discrimination it seems that it has been all the same. Someone with a poor background, economic, and that is coming into the health facility will be discriminated by a feeling of superiority by the healthcare workers, and that's a story that we know for more than a century in Europe. So I have this feeling that history is repeating itself with now other categories of people. That was my comment. Thank you.
Well, I will make it into a question for you. Is history repeating itself? And if so, what might we be able to learn? Well, actually, that would make 5 questions.
I would love to interact briefly. It's not true that racism-linked health disparities are completely the same as socioeconomic disparities. That is not the case. There's very, very, very good studies with huge numbers, especially in UK, US, where you can control for socioeconomic status, and still there is a difference or a disparity in inequity that is racial. So it's not at all the same. But
and I trust the panel would agree, so who can I invite of the panel? Alana first, Charles next.
Yeah, I think obviously there's a lot of similarity, but I think that within the clinical setting, a big driver of bias towards particular racialized groups and therefore health inequalities and differences in the quality of care are driven by biological stereotypes. So if you look at pain medication, for instance, groups who are kind of racialized as Black, with that stereotype comes ideas of particular people having higher pain tolerance or particular biological characteristics that are untrue, but therefore they receive less care, right? And we see the same thing, for instance, for sex, right? Women are more likely to get a sedative compared to males for the same procedure, whereas men are going to get more effective pain medication. And this has to do with stereotypes around those groups. So I think that what's different is are the ideas around race about Blackness, like, oh, they have thicker skin, they have a higher pain tolerance, they're more fertile. All of these biological stereotypes also lead to inequalities. And I think that's the main point of difference also.
I think what I will probably add to that briefly is that, I see it this way. I see that if you are being racial, I think these are multiple. Actually, I would say it's the dose response, right? If you are a minority, you are more likely to get a good job, right? You're less likely to get a good job. And even if you do, that even within the same jobs, in some situations, the minorities pay less than that. There's a whole lot of things coming together. So yes, socioeconomic status and social determinants is very, very important. But I think that what is happening here is that the minorities or whatever, because of discrimination and others, these people end up struggling with the social determinants of health. And on top of that, you then have to deal with everyday discrimination. So all coming together, this is what actually creates the huge disparities that you are seeing. That's also depending if you need control for those socioeconomic status and others, you still see the differences. And this has to deal with these multiple factors these people have to go through. So I think that is, to put it simply, is more than social determinants of health. But the social determinant of health is absolutely important.
And what is helpful for everyone to know, we will be sharing a number of key resources after this session through social media, including the report that really summarizes a lot of this type of evidence beautifully. So I would really encourage everyone to read this. I promise a second person to be able to answer a question, and then we'll go back to the panel for a round of key take-home messages. Please introduce yourself and ask your question as briefly as possible.
I'm Rachel de Jong, I'm a medical doctor. Thank you all. And I would like to ask you, because I would love to contribute in this topic. And I would want to ask you how I can communicate in a way that I can create allies. Because I'm afraid that if I talk about it, I feel like I have to mind my words, because if I talk about racism and I talk with my colleagues like I think racism is a problem, that they will not want to see themselves as such, and that I will lose them in the conversation.
We have a whole room of people who want to be part of making things better. How can they? Yes.
Well, I often give speeches about inclusion and diversity. And my first slide is always, inclusion, if you can't stand the heat, stay out of the kitchen. And what I mean by that is, if you want to address the topic, it will always get difficult at some point. It will always be uncomfortable. And I think we all need to go through it before we can get any further. So if you really want to invest in it, then make sure you can stand the heat.
And Nilu.
Well, I think it's even more important for the ones amongst us that are privileged, especially in the medical setting, where we have to understand that about 70 to 80% of medical doctors and students are from the 20 to 30% richest people in Holland. So we're a very privileged group. And being amongst these privileged groups also gives us a responsibility to speak out on their behalf. And you will meet a lot of resistance. And we just learned from our previous session that we need to move through the resistance, because at the end you will meet a lot of allies. So there's hope, but try to reach out to people that are like-minded.
I would also like to acknowledge it is, especially in the hierarchy that we have, for example, in healthcare, it's not always easy, especially for those who are not yet at the right positions and might be dependent on also their relations with others. So how can, for example, junior doctors also be part of the conversation without, well, they will receive heat, but without navigating how complex it is? Do you have a very short recommendations before we go to the key messages? Who can I invite? Amma?
No, I just wanted to react to what the lady said there. I think it's important to acknowledge that you should not only try to be an ally, but you should actually try to be an accomplice, someone that is actually willing to risk something as well, because you might lose friends in that whole process. But I think it's important to realize that, you know, you need to be willing to risk some things. And I think that's an important thing. And of course, sometimes it's really difficult to take it on by yourself, having these discussions by yourself. And it can help to perhaps say, like, you know what, let's just organize a workshop on this topic, where it's not only your opinion, but where an expert can come in and say, well, this is something systemic or systematic that we see in literature. I think that is a very powerful thing to do.
Organize a group. Don't be the only one saying is, if you're in an organization where you're the only one who recognizes, make sure you're not alone.
Show them the evidence as well.
And
make a copy of the Lancet. Read this.
Let's see. Just place the Lancet Series somewhere, and then different places, coffee tables and coffee machines.
I have some spare copies. Okay.
We do need to move to the final bit of this session, and I am absolutely, I see how much more questions there are. So please also consider this as an invitation to continue the conversation and think about what we can do tomorrow, next week, next month, to continue the conversation and change things. I would like to start online with Michaela to ask her, sorry, I'm pointing here, and this is where the camera is, so that's why we're also looking there. Can you share very briefly, what is your key take-home message of this session as well as the wider topic?
Yeah, thank you for this really interesting conversation. First of all, I've also learned quite a lot myself as a policymaker, and with my, job really being mainstreaming anti-racism into EU policy, which I'm trying to also do with my colleagues working specifically in the health sector. But I think really, the systemic and structural dimension of racism really came out in a strong way today, recognizing this as a systemic problem that also needs systemic solutions, and which, of course, is a long-term project. I think it was mentioned very well in the beginning that normally the interventions on the individual level are short-lasting, but this work that is on policy or on structures and on systems and legislation is the one that takes time, but also is the really sustainable work that in the long run will be the most efficient. Then lastly, I'd really like to mention again that regardless of where we kind of land in this work, be it that we're practitioners or teachers or policymakers such as myself, having that anti-racist approach really is central. And what that means is not only being against racism as a principle, finding it a bad thing, but being willing and ready to have those difficult conversations. It's the active identification and reduction of racism, which is really done by challenging systems, organizations, structures, policies, practices, legislations, and attitudes. And this is what will really lead to true equality, also in the area of health. Thank you.
Thank you.
Thank you.
And let's move over to the stage, Dylan. Can I invite you to go first, and we'll go down this row.
Sure, thank you. I think when I started the work on the series, I set the bar very low in, can we get people to think about this? Clinicians and all the way up to policymakers, can it be on their agendas? One of the things that they think about, and I know that's difficult. I remember, doing clinical pediatrics. I didn't ask about these kinds of questions about how people are discriminated, but I think we should, and it goes at all of those levels. Then, as Michaela said, that this is structural in nature. That's what we keep on coming back to. It isn't about the individual and how they act. It's the systems that they're working in. And then, similar to that, this happens everywhere. This is a global health issue. And one last point, and it's related to one of the questions, how do we talk to audiences? And I think we have to talk in many different ways. There's a group where having an academic paper is useful, but for most of the population, it isn't. And that's what, within Race and Health, we try to do in terms of education, advocacy, engagement. We try to speak in different ways. And for some people, it'll be a comic or an animation or a film or lots of different types of messages in different ways. And I think we need to do all of them.
Thank you. Charles.
I think what I would say is that now you are talking the talk. Everywhere you go, people are talking about diversity. I mean, in the Netherlands, it's fantastic. But are you walking the walk? That is the point here. And that means that, you should not only talk the talk, but you should really start walking the walk, because it's the only that you could actually make a difference. And in doing so, you should not forget the real people over there. It was fine that you academics sitting down here discussing this, thinking about how best you should categorize these groups. But what about those larger populations that actually need it most? We need to get into these communities and dialogue with these communities and come out with the real things that community accepts, right? So in a nutshell, I'll repeat, we need to start walking the walk. We've had enough of talking the talk. Thank you.
Take-home message.
Homework for all of us. Alana.
Yeah, so I guess my main point would be to really try and fundamentally rethink race and really shift the focus towards racism. And I know that there's a tendency to kind of employ what people call strategic essentialism, like, well, we'll just use the racial categories, but we all know they're not real. But in my opinion, that really doesn't work, right? Especially in a medical setting, using these categories really reifies them. So I think it's important to also think about an intervention there, like how can we use categories related to racialization to do the work, but also be very critical of these types of strategic or just blatant essentialization.
Thank you.
I think an important thing that I would like to convey is that when we think about our research on racial discrimination and stuff like that, we're so often focused on objectifying this or documenting this objectively, and we forget that these patients that we're trying to examine and trying to help, that they are the experts of their bodies and their experiences. I think it's important that when a patient says that I felt discriminated against, that we believe that person. So that's an important thing for me to convey, because we know that perceptions of discrimination actually predict health outcomes. So that's an important part. And an other last thing that I want to convey, because in this discussion, we've talked a lot about disparities and differences, and I hate those words. I hate those words.
Go ahead.
I hate those words because when we use these words, we're not acknowledging these systemic structural factors and social injustices that people experience. So I think it's important that we talk about health inequities rather than health disparities or differences. Voilà.
Thank you.
Yeah, so I'll keep it short. I totally agree. I think we should call the elephant in the room what it is. So we should start using the word racism a lot more in Europe,
Yep.
also in medical education, in the way we talk over patient care amongst ourselves. And I think one of the first things we need to handle is our own biases and train ourselves to communicate in a way that we really see the patient for who they are, and really try to connect with them on a deeper level. What do they need from us, without judging and without having our own ideas and biases of what is better for them, to really be a bit more bescheiden, modest, when we treat our patients.
Thank you.
Well, so many things already have been said, so many important things. So it's really difficult for us.
Yes.
But I'm going to give it a try. Sometimes people ask me, and also people from the special training program that I set up, Abigail, am I only here because of my color, because of my race? And aren't you only here because you are a woman and because you have a brown skin? And then I say, it's about time. It's about time that everything that makes me is being appreciated. And that's the first answer. The second answer is, if people think that I or you or we are only going to sit here, be black and beautiful, think again. We make impact. So that is what I want to give all of you also.
No, it's waving. Yeah, clapping. That's clapping.
Okay.
Yeah.
So a lot has been said. I don't know what your take-home message is, but I can tell you what mine is. That is one of hope. I will never forget the triangle that you mentioned. Be ready to feel that it won't feel, what word did you use? No, you used it, saying comfortable. It's uncomfortable. And I would say change the narrative and let's use new perspectives to look at racism instead of reusing the ones that we have. Oh, and transdisciplinary collaboration.
Of course. Of course.
A very short one.
A very short one. So I think I heard also we lack some kind of a research infrastructure.
Very short one.
To do research on racism and how to do research on racism. So I'm looking at where the money is. European Commission, some very experienced European researchers. Is there a room, is there a possibility to create something to do this on European and member state level? But we do not have to wait until we get all the research to already take action now. The need for research cannot be an excuse not to act already now. Thank you.
And that brings me to my key take-home message, and it's actually a question to all of you. There will be a slide right now to ask you what your key take-home message is. And my key take-home message is we all are part of a better system. So my question to you is, what are you going to do? Share your thoughts. We will be sharing it with others, and we hope you will remember this tomorrow, next week, next month, the years to come. So please take some time after we close the session to really think about this. What is your key take-home message? What are you going to do different, better, towards a better, more equitable world? With this, I would like to thank you for your presence, but especially our esteemed members of the panel for your presence here and your contributions. Thank you.
Thank you.
And with this, I wish you a very nice remainder of the afternoon and evening, and we'll see each other either here or in the building or somewhere else.
Thank you for joining us.
Thank you
and join
for
the
joining us.
movement.